All right, well, I think we're ready to begin. Again, my name is Gail Dobell, and I'm with Health Quality Ontario. I'm the Director of Evaluation and Research. And first of all, thank you very much for joining us today. I wanted to take care of just a couple of logistical details before we really get going. Right now, we have everybody on the call on mute, and we're going to leave it that way for a little while. But if you have comments, for example, if you can't hear our voices, then in the top of your screen, you have the ability to send us an email through GoToWebinar. We have folks monitoring that throughout the course of the next hour, and they will alert us if you are having any problems or issues. In terms of the way in which we're going to handle today, we're going to go through a number of different speakers. And then we will open it up to questions in the end. We will be taking all the questions through the GoToWebinar process where you write them in. We do have a rather packed agenda, though, and so if we are unable to get to all the questions at the end of the session, we are very committed to addressing any questions and concerns you may have had, and we will follow up directly with your email and respond back to you in that way. So hopefully we'll have lots of time at the end. In terms of the agenda for today, I'm going to, after I've finished walking us through the agenda quickly, pass it over to Marc Rochon, who is our Interim President and Chief Executive Officer here at Health Quality Ontario, to welcome everybody and make some opening remarks. We will then have a bit of an introduction given by Jonathan Lamb, our Senior Methodologist here at Health Quality Ontario. And then we'll talk about the process of establishing the benchmarks. And to assist us with that, we have Dr. Walter Woodchus and Wendy Campbell. We'll turn it back over to John after that, who will provide us with the values that the benchmarking process identified and the use of benchmarks for setting short-term and longer-term goals. And then we're going to turn it over to two long-term care homes, North Lambton Lodge and the O'Neill Center, and have guest speakers from those two locations talk to us a little bit about how they have been using data in their homes to drive quality improvement and how the benchmarks will assist them in that process. As I mentioned, we'll finish up with a question and answer session, and that should take us to the end of the hour. So at this point, I'd like to turn it over to Marc Rochon.
Thank you, Gail. Good afternoon, everyone. I'm delighted to be here with all of you this afternoon. I imagine most of you are familiar with Health Quality Ontario and some of the work that we do, so we'll just briefly review our mandate with you before we get into the subject matter of today's work with respect to aspirational benchmarks for long-term care. Under the Excellent Care for All Act, H2O has a legislated mandate to report to the public on the quality of the healthcare system, to support quality improvement activities, and to evaluate the effectiveness of new healthcare technologies and services and make evidence-based recommendations on healthcare funding. I'd like to talk more specifically about the first aim of our legislated mandate to report to the public on the quality of the healthcare system. Reporting and measurement define what needs to be improved and tracks over time the progress of quality improvement efforts. It is a critically important component of not only our mandate, but of our broader aim to support the transformation of Ontario's healthcare system. So the learning objectives for today are, in the past, H2O has produced reports that articulated system-level performance and provided advice on how to improve performance. Now we are focusing on defining what excellence or great performance looks like. By associating publicly reported indicators with clear benchmarks, we are now able to both articulate what high quality of care is and measure performance against it. Our hope is that you will leave today with the ability to use benchmarks to inform your quality improvement initiatives, to know the definition of success, to drive quality, and ultimately improve the care your residents receive. I want to thank all of you for taking the time to join us today and for your commitment to improving care for the residents in your long-term care centers. I'd now like to turn over the agenda to Gail, who will introduce our next speaker. Gail.
Thank you, Mark. I'm actually not going to speak long at all. I'm going to pass the baton over to Jonathan Lamb, who is, as I mentioned earlier, the senior methodologist here working on long-term care at Health Quality Ontario. And John is going to just talk to us a little bit about long-term care public reporting, which will lead us into a discussion of what benchmarks are and the indicators that were selected for the benchmarking process. John?
Thank you, Gail. Before defining what benchmarks are right away, I would just like to provide some context on how benchmarks tie into long-term care public reporting activities as well. As most of you will know, HQO reports on long-term care quality indicators via our public reporting website. There are 12 indicators on our website, 4 of which are also reported at the home level as well as the system level. Long-term care indicators are also included in HQO's Quality Monitor, which is an annual report on the quality of Ontario's health system. Over 100 quality indicators are reported in the Quality Monitor. As part of the upcoming long-term care website enhancements, we'll be posting benchmark values for the 4 home-level indicators that are currently on the website. Another key enhancement is to move from annual updates to quarterly updates for these data. So here's just a high-level timeline to tie benchmarks and public reporting and put everything into perspective here. So at this time, we're communicating to you, the long-term care sector, about the benchmarks through events like the webinar. And yesterday, you would have received the long-term care benchmarking resource guide that was sent out to all long-term care home administrators. And this preparation is for the eventual posting of benchmark values on the public reporting website, like I mentioned in the last slide. And around the same time frame, we'll be also moving to quarterly reporting. And this is significant because any improvements that you make at your home will now show up in a more timely manner on on the indicators that we have on our website. And finally, in this coming winter, we're looking to implementing trend over time graphs on our website as well. So with this background in mind, we're now ready to define what benchmarks are. As Mark has mentioned in his introduction, HQO's objective is to support the transformation of Ontario's health system. And as a way to support this transformation, HQO is defining what excellence and high-quality care looks like. And this is exactly what benchmarks represent, the markers of excellence to which organizations can aspire. They also represent good resident outcomes and high-quality care. In other words, these are aspirational values that your homes can strive towards. So with this next slide, I would just like to highlight the 9 indicators that we have selected for benchmarking. As you notice, these are all CCRS indicators. And CCRS indicators were selected because they've been shown to be valid and reliable in the literature, and they're also risk-adjusted, meaning that you can fairly compare one home's results with another's. So the 4 long-term care CCRS indicators you'll be fairly familiar with. The 4 are the ones highlighted in the yellow box. These are all home-level indicators that are on our public reporting website. So these are daily physical restraint, falls, worsening bladder incontinence, and worsening pressure ulcer. The other 5 that were benchmarked were also CCRS indicators, and these are prioritized by our Long-Term Care Advisory Group subcommittee on benchmarking as other important clinical indicators that support quality improvement initiatives. So just before moving on, I'd just like to give a brief refresh of what CCRS quality indicators are. And as all of you would know, these are based on RIMDS data that you collect at your home. And the main focus here is that RIMDS data serve multiple purposes. So not only are they used to calculate quality indicators, which are used to monitor and improve care at your home, and obviously for public reporting as well, but they also trigger clinical assessment protocols or resident assessment protocols, which can help inform your resident care plans. And as you all know, they're also used in the calculation of drugs and CMI for funding purposes. And all of this to say that in order to take full advantage of RIMDS to monitor and improve care, it is critically important that data is coded accurately and submitted to CIHI so that it reflects the characteristics of your residents. And there is support to improve your coding through contacting CIHI and the Ministry of Health as well. So now getting back to why benchmarks are important, and I'll try to demonstrate this through this example here. So from a perspective of Home A, if I'm looking at my indicator results for the percentage of residents who fell within the last 30 days, and I look at my results compared to the Ontario average, from this example, it's clear that I'm doing slightly better than the Ontario average. And after comparing my results to Home B, I'm doing significantly better. However, what I do not know is if I'm reaching a level of excellence or providing high-quality care. So by establishing benchmarks, which in this case is 9%, I can now compare my result with what is considered high-quality care. With this next slide, I would just like to demonstrate how benchmarks and quality improvement also tie together. And homes that have participated in Residents First or have worked on the development of quality improvement plans will know that prioritizing quality improvement areas and setting aims and targets are integral parts of QIP development. So in this graph, what I have here are the 4 home-level quality indicators. The green bar are the benchmark values, and the blue bars are what Home C's performance is. So looking at the gap between the benchmark value and the indicator results, you can clearly see that for the first indicator in the black box, percentage of residents in daily physical restraints, that's where the largest gap is. And this might trigger a home to investigate why this is the case, perform root cause analysis, and at the end, they might then prioritize physical restraint use as a focus area for quality improvement. And when setting targets, they would then be able to set their target to the benchmark value. Of course, this is just one snippet of what QIPs are, and we encourage you to look at Residents First website for more QIP resources. And we'll be providing links for that at the end of this presentation. And at this time, I'll pass it back to Gail to introduce our next set of speakers.
Thanks, John. So with that overview of public reporting and benchmarks, I'm actually going to turn it over now to Wendy Campbell, who's Assistant Administrator at the Stainer Nursing Home, and Walter Woodchus, Associate Professor at the Institute for Health Policy, Management, and Evaluation at the University of Toronto. And they're going to now walk us through the selection process for the indicators and the benchmarks themselves. So over to you, Walter and Wendy.
Well, thank you very, very much. I think Wendy will speak in just a moment, and it's Walter here, and I'll start it off, and hopefully somebody will tell me if they can't hear me well. So I was really pleased to engage as part of the expert group looking at setting benchmarks for the indicators. And I'm just going to speak a little bit to the approach taken in the work of the panel in developing the benchmarks. So the first idea is to set out what the ideal benchmark attributes would be. So not the level, but what would we know about the benchmark? So the first is that it would be evidence-based and data-driven. So it would be real for Ontario, and that there would be a good evidence base that the benchmark is a reasonable target to be achieved in a best practice home. At the same time, it's very important that it be agreeable to local stakeholders. So relevant representatives across Ontario were included to ensure that everybody's local voice really is included and that it makes sense. And what we really want the benchmarks is to be a catalyst for quality improvement. So we want them to energize homes to make those improvements, even among homes that are doing average or better than the average. And that gets to Jonathan's point of earlier saying that knowing what the current practice of all of Ontario is not enough. We actually need to be thinking about what best practice is, and so it would be a catalyst then for quality improvement. And at the same time, they would be indicators of high quality care. So this speaks that these are the right indicators that we're setting the targets on, and homes that are achieving the benchmarks truly are high quality care homes. So there's a number of ways that can actually be used to set the benchmarks. One is setting up a theoretical best rate. So you could do this in a data-driven way if you wanted, saying it's the 90th percentile or it's the best homes achievement. Or the literature might support optimal targets from other jurisdictions. There's also the option of setting rates entirely based on summary measures of current performance, so only looking at the Ontario data. Another way would be looking for best performers. That could be in Ontario, but it could also be across Canada and even internationally. So where homes are really excellent, what are the rates being achieved there? And another way would be just to have an entirely based on expert opinion. So if there isn't a good data or evidence-based approach, then rates could be selected just based on expert opinion. I think that's probably not the only basis on which we'd want to make these approaches. And really, the best approach is what we did, which is to apply a combination of approaches. I'm a scientist and a researcher, so from my perspective, I tend to look for data-driven, evidence-based approaches. And some of the things that I was looking for when I saw the indicators was the extent to which there were variability in the home's achievement of these outcomes, which would point to room for improvement, really. And so that was one of the indicators that would bear in my mind. The modified Delphi approach that we've taken, and I'll explain this a little more carefully in a minute, was really intended to achieve all the attributes of being evidence-driven, agreeable to stakeholders, based on literature, and also locally relevant, and they'd be catalysts for quality improvement. Okay, if we go to the next slide, I'll describe the broad approach that we took. So first, there was quite a bit of background work done by HQO staff, and I'll have to say it was extremely well done. The literature in terms of what other jurisdictions had been achieving and how they went about setting targets and what levels of achievement that homes in those jurisdictions were able to achieve. That was brought to the process as information for all of us to have handy. Also, the selection process, how other jurisdictions set their targets, was also brought into the discussion. So that was all the literature review piece. There was also extensive data analysis by CIHI looking at the results of these indicators across Ontario, but also in other Canadian jurisdictions. And there will be an example of that shown in a few slides. But we were able to look and see, how other jurisdictions in Canada were performing on these same measures. The expert panel recruitment was really meant to provide that clinical knowledge and the right stakeholders into the panels. So there were a number of researchers, myself, Dr. John Hurdes, very familiar with these indicators, Dr. Diane Doran, very familiar with the indicators, and also an expert in nursing interventions, and Natalie Damiano from CIHI. And then there were also frontline medical, nursing, and administrators, and then informatics people. So quite a broad stakeholder group. What we first did was there was an online survey where we went in, reviewed all of the background materials and data that have been provided to us, and looked at all of that information, and then set, we were given an opportunity to set what we thought appropriate benchmarks would be for each of the indicators. After that online process, we came together as a group. So we rated things individually first. Then we had an in-person meeting, and as a group, reviewed the results of the online survey, so where people had rated the expected, what we thought the optimal performance targets should be, and also had a thorough discussion about how we had set those targets. And then came to consensus in that meeting to what the benchmarks should be, and that these are the resulting benchmarks that we have to show you today. Next slide, please. So this is the expert panel membership, and I started to speak to this already. I think I represent down in the data research group, but you can see here very good representation from geographic representation across Ontario, different important groups, frontline nursing, also medical advice about what could be achieved for these people, and that was really important. And then also the administrators are going to be quite key in saying, yes, these are indicators I could take back to my staff and say, this is the target and this is what we're aiming to achieve. So I think I'll pass over to Wendy now to provide a little bit more about that direct frontline engagement and her experience with this process.
Thank you, Walter. As Walter has mentioned, the panel representation was certainly diverse and very reflective of those playing key roles in our sector. Having the scientific community a part of the process was certainly a given, and their insight was invaluable, in particular to me from the administrative perspective. Having the long-term care home representation from both large and small operators, representing both associations at the table, along with the frontline physicians and ministry representation, certainly led to very thoughtful and engaging discussion throughout the in-person meeting. While we all came from various domains, whether it be medicine, research, administration, compliance, the theme and tone of the discussions throughout the day was certainly focused on what constitutes high-quality care for the residents of our homes in Ontario. My goals as a small operator were completely aligned with those individuals from the larger long-term care homes and those of the other panelists. As we move on to the next slide, you can see the type of information that was actually provided to the expert panel. The information, as Walter said, was reviewed by the panelists individually prior to the online survey, and again we looked at it during the in-person meeting in order for us to come to consensus. The first part of that slide shows the indicator description, and that was very important to me. We needed to ensure we were all understanding what the numbers were representing, what numbers constituted the numerator, the denominator, who was excluded from the indicator, and importantly, what individual covariates and or stratification was involved in the risk adjustment of that indicator. The next step the panel took was to review the literature search results, and HQO did a wonderful job of presenting that information to the panelists. Indicator rates and summary statistics from other jurisdictions were studied, as Walter mentioned, including the United States at the state and national levels, the Netherlands, Iceland, and Australia. We looked at the indicator definitions and assessment tools used in those jurisdictions just to ensure that we were comparing apples to apples. We also looked at the thresholds and targets that some of those countries had set as well. Looking at the box plot graph of the indicator performance in Canada was also an important step. Indicator distributions from various Canadian regions, the Yukon, British Columbia, Manitoba, Newfoundland, Labrador, Nova Scotia, all gave important context when considering a particular threshold that other provinces are currently achieving and that which Ontario could strive for. The box plots showed us the 10th, 25th, median, 75th, and 90th percentiles of the provincial rates and provided an excellent visual for the regional distributions across Canada. The fourth piece of information that the panel reviewed was the indicator performance in Ontario specifically. We looked at both the provincial rate and the distribution at a facility level. This was, again, so important to provide context for how long-term care homes in Ontario are currently performing and how spread out the indicator results are. As Walter mentioned, there was certainly variability evident. We wanted to see what percentage of homes were scoring in the various percentiles. This type of information was useful. Not only was the provincial mean and median evident, but the range of the scores was clear. Some homes are already achieving great results, and that data certainly helped us come to consensus on what an aspirational benchmark for quality should look like. When the panel came together for the in-person meeting and the online survey results were shared with us, it was quite surprising and interesting to me that each of our individual suggested benchmarks were really not that far apart. It didn't matter if you were a researcher, a clinician, an administrator from a large or a small home, or a ministry rep. It was quite clear we knew where we were going to land. Knowing the targets being sent were meant to be aspirational. It's not enough to be good enough. We want to be as best as we can be. While I was a member of the expert panel, I have to admit I still had my administrator's hat on, and as I worked through the literature review before completing the survey online and during the in-person meeting, I had my own stash of notes with my particular home's data right beside me. I needed to assure and know for myself and my home where we sat in the percentile distribution and whether the benchmarks being considered were achievable for us. Having the context of the international data, the Canadian data, and especially the indicator performance at both the Ontario and facility level clearly demonstrated to me what is possible. The high-quality performers are out there, and that did influence my suggested benchmarks. We need to look to those high performers for insight in moving us all to that higher performance level, recognizing that the stretch targets will result in bigger improvements for our sector. Walter, I'm sure you probably have your rationale of how you came up with your magic numbers as well.
Yeah, absolutely. Thanks a lot, Wendy. So when I look at this, as I say, I'm a researcher and tend to be more data-driven. I would first look at all the international jurisdictions to get a sense of the broad range of targets that have been set previously. Then I'd specifically look at the indicator performance in Canada and say, how is Ontario performing relative to other jurisdictions? So are we, right in and among the pack, or are we well out in advance already? And that would give me a bit of a sense of how aggressive Ontario could be in terms of setting targets. Then specifically, I would look to the indicator performance in Ontario, the detailed information, and look for the amount of variability. And if I saw that there was a lot of variability across homes in these risk-adjusted measures, that would tend to make me be a little more aggressive and push towards a higher target point, because there are still so many homes that are doing so much better than those, say, the 90th percentile or so. The median, unless Ontario was absolutely fantastic relative to other jurisdictions, and we didn't actually see that, the median wasn't really an option for me, because just being as good as half of the people doesn't seem to be very aspirational or meet the basic criteria that we were looking to achieve. So for me, it was really ranging between sort of moving to the 75th or moving to the 90th, and it had to do with, if it was going to be really hard for organizations to get past the 75th, then I would lean more around that target. Whereas if there were a lot of homes doing significantly better than the 90th percentile, it led me to be a bit more aggressive, just based on the experience and the evidence that we have in front of us. And that was really kind of main points for my my consideration. Can we go to the next slide, I think? So we just want to speak about some of the themes that were discussed during the in-person meeting to give you a sense and a flavor of the discussion that went on. So pretty well universely, 0% would not be an appropriate benchmark for the indicators. We understand that, and both medically, it wouldn't be wise for individuals to be absolutely protected from any risks involved in care. And I think that for most of these indicators, we appreciate that that people are in long-term care homes are older and they are medically fragile, and they're quite complex to care for. So 0 is not really the option. And then it's a matter of deciding on what the right target would be. And so we'd in doing this, we were looking at, first off, the risk-adjusted indicator results. So we're only going to benchmark based on what would be risk-adjusted to control for variation in home-level differences in patient populations and resident populations across the homes. And so that risk adjustment strategy was considered in the discussion. Also, how good that risk adjustment strategy was. So some risk adjustments better than others. And if we had more confidence in the risk adjustment, then I think we felt it would be a truer reflection of the home's actual performance. So those were some of the discussion points relating to the indicator results.
Another discussion point that we certainly had was about the availability of the evidence-based guidelines to support setting those more ambitious benchmarks. As an example, the causes of pressure ulcers and their worsening are well established in the literature, and evidence-based guidelines exist already for prevention. So the expert panel aimed to set targets that were as aggressive as possible based on what is implied as achievable by the current Ontario performance for the pressure and ulcer indicators. We also looked at the distributions of the indicator results within Ontario, as Walter had mentioned. As a group, we decided that benchmarks set at the 25th percentile were not really stretch targets based on the current performance, and benchmarks that were far below the 10th percentile may not be achievable for the sector. So the 10th and the 25th percentiles essentially became the boundaries for us when we were setting the benchmarks themselves. The panel did also have some lengthy discussions about coding accuracy of the MDS 2.0 and overcoding and undercoding. Continuous improvement in coding skills will have an impact on the indicator results. One of the examples that we discussed centered on how the indicator data may show an increase in the percent of residents, for example, whose behavioral symptoms worsened. And while this may not necessarily mean worse quality of care, it may actually indicate better awareness and education in coding of the indicator. Ultimately, however, despite the possibility of seeing that initial increase in an indicator rate, the improved coding of the indicator will better show true improvements in quality care over time. Obviously, coding errors can impact the indicators, and at the end of the day, the key to the beginning of any quality improvement initiative is having accurate baseline data measurement. You can't get to where you want to be unless you know where you're starting from. And it's essential that the homes have their MDS house in order. This alone can help move a home in the right direction in their quest for quality care.
Thank you, Wendy, and thank you, Walter. Just to keep us moving forward, I'm going to pass it back now to John Lamb for sort of the moment we've all been waiting for, and that is to just talk a little bit about the specific values related to those benchmarks.
Thanks, Gail, and thanks, Walter and Wendy, for that information. So as a result of the process that Walter and Wendy just described, the panel eventually came to consensus of all 9 benchmarks for the 9 indicators. And you don't have to scribble these down madly. These are provided in the resource guide that we have sent out yesterday. So the main thing I want to note here is that you'll notice that the benchmark values are all within the 10th percentile and 25th percentile. What this means is that at least 10% to 25% of homes are already reaching these aspirational benchmark values. So in other words, these are ambitious targets, but by no means are these not achievable. And again, I'll just kind of show these here, but they are included in the resource guide and that you have received already. So just in the next few slides, I'm just emphasizing that these are aspirational targets. It might take a home several years in order to reach the benchmark values. So in the next few slides, I'm just going to give examples on how you would use the benchmark numbers and also other additional information to ultimately get to the goal of reaching benchmarks or even getting better. And it's always important to keep in mind during this few next slides that the ultimate goal is always to get to benchmark or better results. So one piece of information that might be useful when looking at setting short-term targets is to consider what typical improvement in the sector already looks like. So what HQO performed here is a very simple analysis looking at the median relative percent improvement of homes that improve for each of these indicators. So I'll just use indicator 1 in this example here. So when we're saying that the median relative percent improvement is 30%, what we're saying is that of all the homes that improved in this particular indicator, at least half of them were able to improve by more than 30%. So what does this mean? In the bottom box where it says interpretation, it's an example of what a 30% relative improvement would look like. So if a home that had a performance in year 1 of 10% and that improved to a 7% for restraint use, for instance, in the year 2, this 10% to 7% drop represents a 30% relative improvement. So again, not to kind of go on about how stretch targets are important, it is something that you should always keep in mind, even when setting short-term targets, that stretch targets are associated with larger improvements. And I want to emphasize that median relative percent improvement that we have just displayed in the last slide, these are not recommended targets, but they're meant to be used in conjunction with benchmarks to set short-term targets. So I'm just going to go through a couple of examples here now on what how a home might incorporate these two information to set short-term targets. So in this situation here, Home D is currently performing at 10% for the physical restraint use indicator, and we know that the benchmark values is at 3%. And from our last couple of slides, the median relative percent improvement is 30%. So if a home is trying to get from 10% to the benchmark value within 1 year, that would represent a 70% relative improvement. So this might not be impossible for a home to do. A home might want to set an annual target with a multi-year plan to eventually get to the benchmark value or better. So their plan at the end might look like this. In year 1, they want to reduce the restraint rates from 10% to 5%. And then in year 2, they'll again reduce that 5% to 2.5%. So it will take them maybe a couple years to reach the benchmark values. So in this example, what we're trying to look at is that even for homes that are far away from the benchmark values, they can set in a plan to eventually get there. And then this second example, we're looking at a home's worsening pressure ulcer indicator. So currently the home is performing at the same level as the benchmark at 1%. And we know that the median relative percent improvement is 31%. So even though they're already at benchmark, the leaders at Home E would still want to improve on their results for next year. And so their year 1 aim might look like this. So they'll look at the median relative percent improvement and plan to reduce that their rates by 30%, relative percent improvement. So their rate, they're aiming to get from 1% to 0.7% in 1 year. And in this example, what we want to point out is that even if a home is performing really well, it does not mean they should stop improving. They should still strive for a better performance from year to year. And with that, I'll pass it back to Gail to introduce our guest home speakers.
Thanks, John. So it gives me great pleasure to introduce you now to Jane Joris from North Lambton Lodge. And Jane is going to talk us through some of the experiences she, as well as the O'Neill Center, have had using data to drive quality improvement and how benchmarks will inform that work. Jane?
Great. Thank you, Gail. So North Lambton Lodge is a municipal home operated by the County of Lambton. 88 people live at the lodge, and it's all long stay. We don't have any short stay beds. We participated in the Residents First Collaborative in 2010. Our home is one floor. We have large secure gardens outdoors, and we have an active auxiliary, family, and residence council. In the beginning of our QI journey, before we had resources from HQO, our QI program was really just reactive. We received a complaint or a suggestion, and we worked on change ideas, but we didn't use data to make decisions or measure success. And the program was really a top-down approach, the responsibility of managers, and we also didn't communicate well about our QI program. So after we attended the Residents First Collaboratives, we learned how to use tools, and particularly the fishbone and 5 whys in the beginning. So we started with issues that we felt could be easily fixed, the lowest hanging fruit. We looked at things that we could see improvement quickly and get buy-in from everybody involved to show that we could make some improvements. We mainly focused on reducing falls and restraints, and we also chose items easily measured so that with improvement we could show the improvement to the residents and the staff and the families, and improved resident outcomes. For our falls program, in the beginning we posted a giant fishbone on the wall, and we had anybody who wanted to put any reasons why people fall onto it. We felt that this kind of introduced the tool as well as where we were going with our change ideas. And when we chose the ideas to work on at that time, people felt that they had input, and we were able to address those issues that people had already given us input into. So we also used items that were addressed in the Resident First roadmaps so that we knew that we were using best practice. One of the things that we already had in place was something called the Resident Safety Committee. And before we started Residents First, we recognized that a lot of resident safety issues were being brought to the Joint Occupational Health and Safety Committee. So we decided to strike a committee to look at resident safety issues. This was before the new Long-Term Care Homes Act, but now that committee acts as our program committee for restraints, falls, responsive behavior, and a few other programs. The committee is interdisciplinary and sets the aims, implements change, and tracks data for any quality improvement issues that relate to resident safety. And you can see the objective here of the Resident Safety Committee, and that we always want to keep a balance between keeping people safe and ensuring safety measures don't adversely affect people's quality of life. Next slide. So I believe that a lot of our success was due to the fact that the same group of people were working on reducing the falls and restraints and also looking at pressure ulcers and continence. We do have different committees working on different issues now, but they work very closely together, and any one of those committees can suggest an quality initiative for the other committee. And we try to make sure that we're always looking at balancing measures so that the work of one program or committee doesn't adversely affect the aims that the other committee is working on. Next slide. So prior to Residents First, we didn't really set aims. Now we set aims usually for a 6-month time frame. We do review them every quarter. We look at what we feel is achievable and if it's a step in a longer-term goal. Another thing that influenced our decision was the acuity of our residents. So at the time when we started this, our CMI was at 0.94, and now it's at 1.07. So at the beginning, we had a lot of people in our home due to spousal reunification who didn't need quite as much support and care as the people who are living with us now. So we were able to get processes in place to make sure that we were reviewing our data and setting our aims properly. We would have a little more difficulty now, I think, to take staff off the floor and get those things done. We also looked at our information from CIHI regarding the provincial averages, and we tried to be either on those averages or a little bit better than those averages. Some of the successes that we've had is reducing falls soon after admission. We implemented a new assessment process and checklist for falls on admission, and we found that a high percentage of our falls were happening within the first 2 weeks of admission. We've managed to reduce those numbers dramatically. We also had high numbers in residents who are at risk for dehydration, and we discovered that the documentation was really an issue. So we put quite a bit of work into that over a number of months and developed a point system that we put in point of care so that the staff didn't have to add up the amount of liquids that people were getting. And that's been a big success too. We did have some challenges with our falls and restraints. We had put in 30-minute checks, and the staff felt that they had to take a clipboard around and go and check where everyone was. But we retrained people to keep track of when they saw someone within the time period and record that. So instead it was part of their workday and not in addition to their work. When we set an aim and implement change, we sometimes didn't test the change fast enough. And by the time we realized that we weren't really going in the right direction, it was hard to stop or realign it. So we've learned that we need to test change quickly after we've implemented it. So how are we going to change how we prioritize our quality initiatives and aims with the new benchmarks? Our mission says that we'll provide high quality long-term care. So we've decided we need to exceed the provincial averages and use best practice at all times. We're pretty excited about the new benchmarks because that's going to give us some direction in setting our aims. We want to ensure that our change ideas and our processes are in line with best practice, and we found that the most successful initiatives that we implemented are important to have everyone involved. When people felt that their input mattered, we were much more successful. We also want to make sure that our successes are sustainable. So if we're making change, we need to ensure that the processes are in line with all of the work we are doing and it doesn't contradict other work. And I know that everybody is aware there's so many new things happening all at once. And at the moment we're doing a lot of work on BSO and responsive behavior, but we need to balance any changes made in that work with the other work that we're doing. So making sure that we're checking in with all of the aims that we have in our QI program throughout the year, that they're not contradicting each other. So what we're going to do is push ourselves to increase our targets, use the benchmarks, and we feel if we set higher aspirations that we'll have more successes. And we're also going to test often to ensure that we're making the right decisions.
That's terrific, Jane. Thank you very much, Jane. I'm now going to pass it over to Cheryl Ho and Jean Smith from the O'Neill Center.
Great, thank you. So good afternoon, everyone, and thank you to HQO for hosting this very informative webinar and for the opportunity for us to share in this way. I am Cheryl Ho, and my role is a RIE coordinator and quality improvement coordinator, and with me is Jean Smith, who is our accreditation coordinator, and we're representing the O'Neill Center, which is a 162-bed long-term care home and retirement home in downtown Toronto. We have been following the Residents First philosophy for several years, and we've been very much dedicated to quality improvement. And today, we just want to share some of the ways we're using our data to help drive our quality initiatives in the home. Quality improvement is a continuous process, but when we're wanting to begin our quality initiatives, it all starts with gathering, reviewing, and analyzing our data. So when we're establishing our quality initiatives, we look to many data sources, but one of the primary sources is our CIHI new generation quality indicators. Initially, we review our indicators to determine where our priority areas will be. And of course, there are several areas, several care areas which you may want to address, but for this purpose, we can't do them all at once. So we want to identify a couple which are of the highest priority and then focus our efforts there. When we're reviewing our quality indicators to find our priority areas, we give the highest priority to those areas where we are not maybe doing so well compared to the provincial averages, or maybe we're doing well compared to provincial averages, but we are seeing an unfavorable upward or downward trend. And pertaining to areas which are of the highest risk to our residents' quality of life and well-being. So, for example, falls, as we know, can lead to pain, debilitating injuries, and in some cases, death. So the next slide I'm showing is a sample of our home's quality indicators to just illustrate an example of how we will narrow in and target our priority areas. And just to orient you for a moment to the chart, on the left are the indicators, and in the center is our home's percentages, and to the left is Ontario's percentages. Red areas indicate areas which we're not doing so well compared to comparing our benchmark with the provincial averages, and yellow indicates we're close to being worse than provincial average. So when we look at our data as a whole, we start by focusing in on the areas where we feel are the greatest risk to the residents' quality of life and well-being. Of course, worsened pain, worsened bladder continence, worsened pressure ulcers, falls and restraints, etc. And those indicators that have the benchmarks attached to them now are really good ones to focus in. So those the benchmarks will help us to identify those high-risk areas. Of course, there may be other indicators which are maybe not doing so well compared to provincial averages, but it's not to say that we're going to ignore them just because they may not be in one of the highest risk areas. They will be addressed, but at this point, for determining where our priority quality improvement initiatives will be, we like to focus on those highest risk areas so we can zero in on them. The next slide is all of the high-risk indicators. And I've also included has had weight loss because our home does have a quality initiative for weight loss in place right now. So we did find that a trend with residents who were developing pressure ulcers did have recently an unplanned weight loss. So this is definitely one that we want to keep on our high priority list. So from here we can zero in on some areas which we're not doing so well compared to the provincial average, or we're seeing an undesirable trend. And with worsened ADLs, worsened behavior symptoms, and worsened mood, these areas are all doing well and continue to come down, so I won't include them in my prioritization at this time. And in my next slide, we're focusing on falls, restraints, worsened continence, and worsened pain. So these indicators are all below the provincial average, but there's a slight upward trend. So we definitely want to continue to monitor and ensure processes are in place to prevent any further increase. Of these, the worsened pain is closest to the provincial average. So this is one area we are going to set as a high priority focus when determining our quality initiatives. And since pressure ulcers have only recently come down to below the provincial average in 2 out of the 3 indicators, one indicator, that is the Haas pressure ulcer percentage, continues to be above the provincial average, so pressure ulcers would be identified as another high priority area for quality improvement. Also, worsened pain and worsened pressure ulcers are 2 out of the 3 indicators that, which are above the benchmark, so that would also help to validate the decision in making these our prioritized initiatives. The other indicator which we have some room for improvement is the worsened urinary continence, which is currently 12.8%, and the benchmark is 12.0. So although it may not be our main priority focus at the moment, we'll definitely be keeping it on the radar and ensuring a team is tracking and working on that. So then our priority areas being then our pressure ulcers and worsened pain. And of course, this is just one example of how you could prioritize your initiatives. We also like to use the priority calculator as part of the Residents First tool when we have several indicators and we're trying to determine which are the most important for our initiatives. When we're choosing our priority areas, it's also very helpful when we use a team approach in reviewing those indicators. So now when we have our priority areas are identified, a quality improvement team is established, and so we have one for pressure ulcers and one for pain management, for example. The team will review the data and do some analysis to find out the root cause of the issues. There are many tools to do the root cause analysis, and the Residents First package can help with that. Once some of the causes have been identified, you're better able to set meaningful aims and objectives. We like to set a long-term goal, an aspirational goal, and now moving forward, now that we have the benchmarks, that will help with setting those long-term goals. And from there, we like to set our short-term goals, which help map out the process or are leading the way to achieving our long-term goal. In this slide, we have some examples of what would be a short-term and long-term goal. So if we're looking at preventing pressure ulcers, one indicator which we track is also the number of facility-acquired ulcers, and we track this on a month-to-month basis. So a short-term goal may be to reduce the average number of facility-acquired pressure ulcers from 2 a month to 1 a month by July of 2013. And in terms of a long-term goal, we want to have no more than 1 facility-acquired pressure ulcer every 3 months, or, and we are using our benchmark here, 1% of worsening pressure ulcers by December 2014. In terms of weight loss, in terms of preventing worsened pain, our goal may be to reduce the percent of worsened pain from 8.7 to 7.0 by Q3 of 2013, so that's the end of this year, and a long-term goal of reducing the percentage of residents with worsened pain to 6% or less. So again, we're looking at the benchmark by December of 2014. Some challenges, of course, with the amount of data that we do have available to us, it can be difficult to really narrow in and choose data which is going to be most meaningful. So that can be challenging, but when we focus in on our priorities and we do our root cause analysis, it's really it becomes easier to choose indicators which are going to be most meaningful in helping us track whether or not we're meeting our goals. And with successes has been, in general, just focusing on the quality over quantity. So really focusing in on the highest priorities, choosing very meaningful indicators, and working as a team, being creative, having fun, can all be contributing to overall success with the program. I'd just like to thank you for the opportunity to share, and I wish everyone the best of luck.
Thank you, Cheryl, and thank you, Jean, also, who I know is there with you. I'm a little sensitive to the time and that we're reaching our 1 hour, but there's just a few more slides, so if you can bear with us, that would be fabulous. I wanted to just do a little bit of a summary now of what we have heard thus far today, and then I'll take it into some next steps and some questions. And thank you for submitting your questions. We've received a number of questions throughout the webinar. If we don't get to them in this session, we will be responding via email. So in terms of just a quick summary, I think what we've learned today is that benchmarks are markers of excellence against which high-quality performance can be measured and used for quality improvement planning by informing the prioritization of quality improvement initiatives, as well as home-level targets and aims that will help you work toward the benchmarks that we identified today. Benchmarks were identified using an evidence-formed process and an expert panel. The values were identified for 9 of the CCRS long-term care indicators. That's a rather short summary for a lot of information that we've shared today, but I wanted to make sure that we acknowledge the time and the contribution of the Long-Term Care Advisory Group Subcommittee on Benchmarking, the expert panel that has been with us all through this process, all of today's guest speakers, as well as the HQO staff, who has done a magnificent job in pulling today's webinar together. Just in terms of summarizing a little bit what the next steps are, and this will address a number of the questions that came up that you've emailed to us, that a questions and answers document will be circulated to all the long-term care administrators via email on April the 24th. So that's all the questions that have come in today. We will answer, plus some other ones that we think might be relevant to you. The resource guide that we have made several references to that was distributed to administrators yesterday will be posted online on April the 26th. And in the fall, the benchmark values for those 4 publicly reported home-level indicators will also be posted to the HQO Public Reporting website. There's a couple of other slides that I just wanted to be aware of, and those are, again, acknowledgement of the individuals who are participating in our group for the benchmarking webinar, as well as a number of different resources that can help guide you through the process of quality improvement and using data to drive that quality improvement. One of the questions that came through from a number of people was, the information that you provided in the deck, will that be available to us? And the answer to that is yes. We will be sending out this deck as well. So those resources that you have up on your slide now are also going to be available to you.
And in addition, this webinar is recorded, so we'll be posting the recorded webinar at some point in time as well.
Terrific. So I'm now turning over and just looking at a couple of the questions that have come in, and I think we have a bit of time to answer 1 or 2 of them. The first was the webinar slides, will they be available, and the resource guide. Yes, they absolutely will. The next question was, what was the process for selecting the expert panel members? John, do you want to take that question?
Sure. So one thing that we looked at was really, we wanted to make sure that the panel is representative of the different geography in terms of home size, and we also wanted everyone on the panel to be fairly familiar with RIMDS data. So that was the first requirement, so that they had to be familiar with the RIMDS data. And the other 2 approaches were looking again at the representation for the organizations and also the expertise. So as Walter and Wendy have talked about, we looked at people who had research expertise as well as clinical expertise. And the process in getting these people nominated, we went to our long-term care, the subcommittee benchmarking the subcommittee on benchmarking, and we looked for them to nominate individuals. So this included the OLTCA, ONUS were also involved, and also people from the research community like Dr. John Hurdes was also on our subcommittee.
Thanks, John. While we still have the long-term care home guests on the line, I thought I'd actually turn to a couple of the questions that were specific to those homes. So I'm going to read the first one out, and this referred to Jane Joris's presentation from North Lampton Lodge. The question is, this looks great. However, are you aware of the definition of restraints with RIMDS include tilt chairs? CIHI uses the data as a restraint. Our home uses tilt with chairs for positioning, not for restraints. We actually have only one seatbelt restraint in the whole home. However, our numbers don't show that. Therefore, we are not sure how to reduce this number and get to the 90th percentile. Jane? Jane, are you still on the call?
Yes, I am. I'm just thinking.
Okay.
We have a few people in tilt chairs, and we have instructions in their care plan about how often that is to be repositioned. And to give you some individual information about that, you could contact me directly.
Terrific. Thank you, Jane. Actually, Jane, while we still have you, there was another question related to North Lampton, and that was, will the speaker provide more information on the point system that you use with the POC to track fluid intake?
Absolutely, we can do that too.
Terrific. There was a question about how do we get reports for individual homes, and I think the reports for the individual homes can be achieved through through the Canadian Institute for Health Information through their online e-services reports or e-reports. So I think you can receive your results for those indicators that way.
Yeah, and for more information about that, you can email ccrs@cihi.ca.
Terrific. And there was a question here about the definition of restraints. John?
Right, so the definition of restraint here, we know that it's different from the legislative definition of restraint. So this uses the RIMDS. So so intention here doesn't matter as long as you're not able to remove the restraint yourself. That counts as a restraint in this instance. So I know that in the legislation, there needs to be intention to restrain this individual. So I know that this is has always been a difference. I'm not sure if Gail, anything to add. I think it's a ministry definition versus the RIMDS definition.
Thanks, John. The next question that came in is this data adjusted for acuity before it is reported on the website?
Yeah, so these are all risk adjusted. So for more information on risk adjustment, you can email us directly, but in the sense where we look at all these, everything is risk adjusted on 2 levels. So acuity is taken as one, so they're stratified sometimes either by the CMI values, or they could be stratified by ADL, for instance. And then we use covariates to adjust each individual level strata. And again, for more information, please email us, and we're happy to either talk on the phone or we have some documentation that we can share with you as well.
Terrific. I think in the interest of time, I am going to stop us there. But again, on behalf of Health Quality Ontario and Mark Rochon, we are so appreciative that you were able to participate in this webinar today. If you do have additional questions or feel that your question wasn't addressed, then we are very happy to feed back more information to you. And we will be doing a follow-up survey, and this is the link that you have up before you now. We'll also be emailing this out to everyone who participated today. So please, if you can, fill this out and help us to do an even better job next time. Thank you again for participating.
The organizer has ended the session, and this call will be disconnected. Goodbye.